The standard of care for men with metastatic castration-resistant disease has evolved drastically over the last decade, if not more. I think we now have a plethora of agents that we can use in the context of this situation. I would argue that you can pocket these treatments into oral therapy, chemotherapy, and radiopharmaceuticals, if you will. In the context of where this patient stands, the standard of care right now with the existing data that we have could be, in fact, to initiate the patient with oral therapy. And there's a series of agents that can be actually used in this context. We have the Prevail data. We have the Cougar 302 data that supported and led to the registration of agents such as abiraterone acetate or the androgen receptor inhibitor enzalutamide. So either of these two agents would have been a viable option for this patient. The second bucket, if you will, that one can think of for managing this patient could be cytotoxics, if you will. Now, docetaxel remains the frontline cytotoxic agent of choice for most men with metastatic castration-resistant disease. And I would argue that we move away from the need for symptoms to be able to document the use of docetaxel. I think for many years, the NCCN guidelines sort of restricted docetaxel to people with symptomatic disease. And I think finally we move away from that. And if you look at and remember the historical data that led to the FDA approval of docetaxel, specifically the TAX-327 and the SWOG 9916, those two trials did not really actually mandate for people to have symptomatic disease. It was just whether or not you have metastatic castration-resistant disease, regardless of symptoms or not. So this patient could be a candidate for oral therapy. The second bucket could be for patients like him, could be initiating docetaxel-based chemotherapy. The third bucket that I forgot to mention earlier could in fact be the use of immunotherapy. The IMPACT trial, which is the trial that randomized patients like him with metastatic castration-resistant disease to either sipuleucel-T or placebo, clearly demonstrated a survival improvement in favor of sipuleucel-T. So this could be another solid option for this patient just by virtue of the outcome improvement. And I can dissect a little bit more as to why one may pick one over the other one in a bit. The fourth bucket that you can think of, obviously, would be radiopharmaceuticals. So this is where Radium-223 perhaps come into place, and maybe the reason to some extent why whoever was treating this patient elected to use Radium-223 as a radiopharmaceutical. So Radium-223 was also approved in the United States, several years back by virtue of the ALSYMPCA data, a trial that actually was mostly conducted in the European region, but really demonstrated that if you take men with metastatic castration-resistant disease, with mostly the trial was some people with symptomatic disease, but if you really dissect the data, almost half of the patients, a little bit less than half of the patients were not taking opioid medications for pain control. So really you have a bucket of patients that are not taking opioids, what we used to call in the Prevail and the Cougar 302, perhaps asymptomatic or minimally symptomatic metastatic castration-resistant patients. But the important part is, ALSYMPCA demonstrated that if you add Radium-223, which is an alpha emitter, for this patient population compared to placebo plus the best supportive care at the time of when that trial was conducted, there's a survival benefit in favor to those who receive Radium-223. So I think that those are sort of the buckets of treatments that patients can use in the context or physicians should be thinking of in using when you think of when you see someone with metastatic castration-resistant disease, even in the minimally or symptomatic space. Now, how do you dissect which is the best option and how do you sequence the treatments and how you layer these options remains controversial. I don't think we really know if oral therapy is better than chemotherapy as a frontline agent for these patients because that data has not been really prospectively validated. The reality of it is most of us in the US setting probably will try a patient like this on an oral agent first. But I think the data with ALSYMPCA would certainly support the use of Radium-223 for this particular patient.